This lecture will cover a series of respiratory system disorders, talking about a little bit of pathology and some of the ailing conditions that may impact a number of different athletes. So with that, we'll begin with athletes and pulmonary conditions. And so oftentimes, what might be aptly described as difficulty breathing or shortness of breath may be things that we routinely see in terms of a medical emergency. Now, in some cases, we need to recognize and put context to the situation. If a player just comes off the field after sprinting after a ball or creating a bunch of series of short bursts of effort, and then they get subbed out and they come off the field and they are short of breath, right, breathing heavy and rapid, that may not be of concern. It may be something that was anticipated. But if we have a player that's sitting on the bench and all of a sudden they develop this wheezing and difficulty breathing and can't catch their breath, well, that's certainly a very different issue and one that needs to be addressed in a very timely manner. Now, the difficulty is that some of these symptoms are subjective and may not always indicate pathology. So if we look at dyspnea, the second bullet there, may be associated with the respiratory system or suboptimal function of oxygen transport leading to rapid ventilation. And if you recall your anatomy and physiology, you'll recognize and remember some of our mechanics of ventilation and some of the changes in pressure as we draw air into the lung, increasing pressure, forcing air out. Certainly recognizing that there could be disruption in the mechanics, whether we have aspiration, whether we have some type of foreign body airway obstruction, right? That can all change how we go about breathing. And certainly we have cellular respiration, and where we would be looking at gas exchange physically moving across tissue membranes from the lungs into the blood, if we're talking about movement of oxygen, oxygenating red blood cells to then be circulated to the systemic circuit. In addition, cellular respiration would also include carbon dioxide built up in the muscle, making its way into the blood, circulating back to the lung where we would breathe it off. And so there may be some diagnostic tests that an athlete may undergo as we try to identify whether or not pathology may be present. Certainly we understand that if there's a dramatic change in a person's performance, that may be worth looking into. For instance, you have an athlete that regularly participates in high levels of physical activity with no problem. Well, now all of a sudden we have an athlete that can't sustain long duration exercise, has difficulty, with certain levels of activity. That may be something that would be more critical. We need to analyze and diagnose. So there's a couple here, and there's a couple on slides that'll come in the future. But some of these diagnostic tests would include spirometry and pulmonary function testing, in which case we'd be looking at pulmonary volumes and airflow. We're going to talk about that with a little bit more detail in just a moment. Now, arterial blood gas determination may be really important in terms of recognizing how the body is engaged in respiration. Certainly, if we examine arterial venous oxygen difference, recognizing how well we're saturating blood on the arterial circuit, how oxygen is being consumed at the muscle, and then what it looks like on the back end in the venous circuit, we can determine, number one, oxygen consumption. We can determine how well the body is then using and consuming oxygen, but also if there's a level of carbon dioxide that's being built up. If we look at levels of bicarbonate, we may also look at, in terms of blood, look at serum pH and changes that may occur in the blood itself. So there are a number of different mechanisms that may be used when we talk about some of the pathologies that you'll see here in this slide set. Pulse oximetry, we're probably well aware, measuring arterial oxygen saturation, typically at the capillary bed, right before that blood is being, right before the blood undergoes respiration. And so we're getting a pretty good indication of how well the person is saturating. Now at rest, we might look at a value of 98.5%. Some readings, if we were to measure 100 different athletes, we'll have 98, 99, possibly 100. But most of the time, we tend to reside at a resting value around 98.5%. Well, that resting value would be at sea level, 760 millimeters of mercury. As we go up to altitude, the body undergoes some additional stressors. Some of those additional stressors would include a reduced partial pressure of oxygen. And that reduced partial pressure of oxygen creates some difficulty in gas exchange, resulting in a decrease in arterial saturation. And so a value at rest up at altitude, let's say we're at Pikes Peak, maybe 4,300 meters, 14,000 feet, give or take. Maybe this person is saturating 90%. They start exercising, and now we find an athlete who's saturating in the high 80s, in the mid 80s. How high is the intensity? In the low 80s. So recognizing pulse oximetry as a method of diagnostics also requires context. Because if I look at an athlete at sea level with an oxygen saturation after playing, comes off the field and they have an arterial saturation of 80, I might have a little bit of concern. Most of the time, athletes, even the most elite athletes, do not experience a significant level of oxygen desaturation, even at high or maximal levels of activity, meaning that they tend to remain at about 98%. Some might find a decrease, but we're probably not decreasing more than about 92, 93%. So if an athlete comes off the field at sea level and we look at a pulse oximetry, they're really experiencing shortness of breath, difficulty breathing, measure pulse oximetry, and they're now in the 80s, I have a little bit of concern if we're at sea level. Now, if they come off the field short of breath and we're at altitude and I measure and they're in the high 80s, I'm probably looking at that scenario a little bit differently. Exercise tolerance testing might be very important in terms of diagnosing some ailments. And so for athletes who don't exhibit signs and symptoms during resting tests, they may experience certain signs and symptoms during exercise. And that may be required. Exercise testing may be required for identification of pathology. For patients with chronic pulmonary disease, we might again identify some manifestation of some signs and symptoms that may not necessarily be prevalent at rest, but during exercise, even at low levels, walking 3.5 miles an hour, we may experience or exhibit signs and symptoms if we have chronic pulmonary disease. Now, one of the areas that I mentioned a moment ago was spirometry testing, and this would be a method of testing pulmonary volumes and airflow times. And on this figure, you see a standard tidal volume and then a giant big deep breath in and a big breath out and then back to normal breathing. And a big breath in and back to normal breathing. Now, it's this one here, this FVC, that tends to be very important in terms of our diagnosis. So this would be normal breathing, about 500 milliliters of air. We take a deep breath in, and after an maximal inhalation, we're going to ask our athlete to breathe out as hard and fast as they can and to breathe out as much air as they can. And they're going to keep breathing out, breathing out, breathing out until there's no air left in the lungs, and then take a deep breath in. So we ask the athlete to do that. They take a maximal breath in and a maximal breath out. You keep breathing, keep breathing, keep breathing. This takes about 2 or 3 seconds here, maybe 4 seconds. All the air is breathed out and back to normal breathing. Now, I say all the air is breathed out, but we obviously recognize that we have some residual lung volume remaining. And if you recall discussions back in exercise physiology or in a human physiology class, you may recall that residual lung volume is very important in terms of maintaining some of the respiration that occurs even when as much air as possible has been removed from the lung. So residual lung volume maintains a degree of importance. So when I say all the air out, that's the cue that I would give to the athlete, recognizing from a physiologic standpoint, they're not breathing all their air out. There's going to be some left over. Now, this can be measured with oxygen dilution or different tests or different methods, but that's not important for this lecture. Okay, so as I ask the athlete to breathe out, I'm going to measure this amount of air breathed out over time. So let's say this along the x-axis is time, and this is time point 0. Let's say 1 second occurred right about here. So let's say this amount of air from here to here was breathed out in the first second, and then over the next 1 second, they breathed out an additional amount of air. We're going to measure that amount using what's called forced expiratory volume in 1 second, compared to forced vital capacity, which is the total amount of air that a person was able to breathe out. If we look at the ratio of FEV1, forced expiratory volume, in the first 1 second of breathing air out, and we divide that by the forced vital capacity, that's going to indicate pulmonary airflow capacity. Now, that's very important in terms of diagnosis. And this, we have certain criteria, which I'll talk about in just a moment, but it reflects pulmonary expiratory power and overall resistance to air movement upstream in the lungs. And it could give us some indication of some obstructive or restrictive pulmonary disease. Now, I'll point out here, this bullet, that FEV1 divided by FVC is approximately 85% in healthy individuals, meaning that if I ask my athlete to blow out as much air as they can, as quick as they can, in the first second, they tend to exhale about 85% of the total volume that they were able to move out of the lungs. For somebody who's less healthy, perhaps with an obstructive disease, bronchial asthma, COPD, if I ask them to breathe out, number one, they may be able to breathe out lesser volume, but number two, if we look at how much is breathed out in the first second compared to the total amount of air breathed out, we find that a person with a ratio less than 70, that's our indication or delineation point for an airway obstruction. So we use this global initiative for chronic obstructive pulmonary disease. These are things that can be done in the lab. There are a number of different devices in terms of spirometers that could be used, ranging from a $500 desk unit to an $80,000 metabolic cart, which has a lot of bells and whistles that does a lot of other things aside from pulmonary function testing. So one of the things that we'll do is we'll use this airway obstruction classification of FEV1 divided by FVC less than 70 gives us an indication of airway obstruction. And then we would be able to look at the disease severity. So if we are less than 70, we're classified with a disease. How bad is it? That's going to be dependent on your FEV1 value. Now we have some other metrics and normative values for age and sex to understand what would be expected. And then based on what's expected of an FEV1, that gives us an idea of how severe a person's airway obstruction is. We have some other diagnostic tests, and certainly imaging and radiography can be helpful in evaluating presence of tumors, perhaps those that are residing in the lung and soft tissue, evaluating particular infections, so identifying some areas on a radiograph that would indicate pneumonia or tuberculosis, and some of those have been seen in previous lectures. And then we could do some biopsy of the area in the bronchi and check for a site of lesion or bleeding to identify with this scope whether or not there's some compromised tissue in an area, whether there's a clot, whether there's bleeding. So this, again, with diagnostic testing can be helpful in identifying a pathology in that respiratory passage. And then if we had to undergo additional testing, perhaps culturing, taking a sample, maybe taking a sample of sputum or mucus, in some cases maybe a biopsy of a tumor or something that's present within the lung, and then testing that for the presence of pathogens and determining antimicrobial sensitivity of the particular pathogen to aid in the prescription of some type of medication to aid or resolve in the pathology or disease. There's also a variety of different methods that the body uses to reduce lung infiltration of pathogens. And we're familiar with sneezing and coughing. Now, sneezing and coughing both tend to be these responses to irritation, right? Sneezing being irritation in the upper respiratory tract, and coughing with inflammation or foreign material typically in the lower respiratory tract. So the sinuses, we understand these are lined by this continuation of the respiratory mucosa, which consists of this pseudostratified ciliated columnar epithelium. And obviously, if we're familiar with epithelial cilia, then we understand that it could include trapping some mucus, and we have these goblet cells that secrete mucus, which essentially the mucus acts as a first line of defense, right? It's kind of this trap that's going to collect foreign particles and dust and pathogens. And the cilia are these little hairs that are going to sweep the mucus and debris up and out of the respiratory tract. So if we have some irritant, we have some pathogen, we're developing mucus to kind of collect and trap it, and then coughing or sneezing to remove that respiratory pathogen from the body. So excessive amounts of mucus, right, which some of us have had if we're sick or we have some other type of irritant, those are obviously going to stimulate, perhaps in some cases a cough, and sometimes you expel this mucus and material away and out of the lungs, and that can be helpful in terms of ridding the body of some of this pathogen that's been collected. Smoking is a problem in some cases because if you're aware of smoking and its impact on the lungs, we're aware that it causes some disruption of the cilia, and therefore this irritation caused by smoke can actually cause some replacement of the structure of the lung from what would have been the ciliated epithelium to now these squamous cells, which unfortunately don't have the same protective characteristic or mechanism as the ciliated cells. And so by smoking, we essentially are removing some of our protective mechanism. Now, I mentioned coughing being a method to remove some of the foreign material from the lower respiratory tract, and that could result from nasal discharge, right, dripping into the oropharynx, and inflammation from foreign material like tobacco smoke. And sometimes, we may actually be, in some cases, prescribed medication that tends to help break up some of the stuff in the lungs. And that may help with excess secretions becoming an ability to remove. So we have an expectorant, a medication, which may be prescribed by a physician or sometimes an over-the-counter, which can be used to help to remove some of these secretions. So thick and sticky mucus that's particularly difficult to get out of the lungs may be aided in removing from the lungs with medication. We also, if somebody's trying to sleep, it's maybe not beneficial to have them trying to cough things up while they're sleeping. So it may, in such cases, be given a cough suppressant, right, like codeine or something like that, used at night to help with easing some of the symptoms and allowing a person to get to bed. Obviously, sputum has a number of different colors that can indicate different things to us, and on the screen you see there some examples of yellowish green or rusty or dark colored, large amounts of sputum with bad odor, thick tenacious mucus. Hemoptysis can also be a problem, blood tinged frothy sputum. Those of you that said, that sounds a little bit like pulmonary edema, would be correct. And it's important not to confuse hemoptysis with hematemesis, which is vomiting up blood. So if we had vomiting up blood, that would typically be more granular and dark in color, almost like coffee ground vomit. And that'd be very different from hemoptysis, which would be typically a more frothy type sputum. So recognizing different types, and oftentimes you may have been to the doctor and say, hey, have you been coughing up any mucus? What color is it, right? What color is it? Because if it's yellowish green, that often indicates bacterial infection, or they want to know this. Or is it rusty or dark color, right? Could be signs of pneumonia or something along those lines. We also have indications when we're doing some diagnostics of breathing patterns, and this might indicate to us a person's ability for ventilation and respiration. So you see on the figure here a number of different types of breathing patterns, and I like this figure because it kind of gives this regular type of breathing, and then tachypnea, which would be a fast breathing, or if we say bradycardia, we're talking about a slow heart rate, or bradypnea, which would be more of this slow ventilation, apnea obviously being no ventilation, hypernia, a little faster. And then we have these other things, Cheyenne-Stokes respirations, and ataxic breathing, and Kussmaul respirations, which typically represent deep and rapid respirations, kind of this often been characterized as air hunger, and typically may result in a response to a state of acidosis, trying to provide some additional ventilation to kind of create a more basic environment, blowing off some of the CO2. If we're familiar with some of the gas exchange that occurs in the body, the level of ventilation may aid in changing blood acidity. So again, sometimes the response of the body is in a protective method for something that has developed in the blood or something along those lines. And then that third bullet, labored respiration, prolonged inspiration and expiration, often associated with obstruction of airways, can be problematic. So again, if you wanted to read through each of these, I won't go through them one by one, but certainly pause the video and you'll be able to look at some of the respiratory patterns. Now, certainly, if we were to listen to the lungs, we might be familiar. There may be multiple areas of the lungs on the front and the back of the chest and back that we would want to look at, perhaps on the sides, underneath the armpits. And as we look at lung sounds, we're not just listening for presence of air movement, but we're also looking for the type of sound that we hear. So do we hear something like rhonchi, which typically rhonchi in the bronchi, right? Or are we looking at wheezing or whistling, or stridor, which is this more high-pitched type of noise? Or do we have an absence of breath, right? Which could indicate some non-aeration of collapsed area of tissue. And atelectasis might be an indication of a complete or partial collapse of the lung, or a particular lobe or area of the lung. And so typically atelectasis occurs when these alveoli within the lung become deflated, or sometimes in some cases filled with fluid, or some other type of alveolar fluid, and can cause some challenges with ventilation and also respiration. So certainly go on to YouTube, familiarize yourself with these sounds. There's some great videos out there as an additional supplemental resource. Now, for your reference, we'll kind of talk about some of the etiology, what might cause some of these breath sounds. So if you go to YouTube, you look up these sounds, you listen to them, you say, okay, that's what I hear, that's what I anticipate when I'm expecting rales, right? A light bubbly or crackling sound with serous secretions might indicate to us a number of different things, including pneumonia. But maybe we're looking at somebody with fibrosis, like cystic fibrosis or pulmonary fibrosis. Maybe it's something with bronchitis. So we have rales, we have rhonchi, which I indicated typically occurs more in the bronchial tubes. And that could be due to a thickening with mucus or some type of inflammation like bronchitis. Again, COPD may manifest in a couple of different sounds. If there are no sounds, certainly we're looking at some problems that need to be resolved immediately. That's not normal. But it could be a bronchial occlusion, for whatever reason, if we aspirated something, whether it was a food particle or some other material that caused the area of the lung to become blocked, such that we can no longer ventilate an area. If we had a collapsed lung, you may have heard of pneumothorax or some other type of pleural effusion. Some paralysis of the diaphragm, typically on one side or the other. Paralysis could cause some challenges with ventilation of a particular lung or complete ventilation of certain lobes. And certainly intercostal muscles, as we understand, expiratory is aided by our internal intercostals, and inspiration is aided by our external intercostals. And so recognizing that some of the challenges for absence of breath could be related to some muscular issues as well as other challenges, as I mentioned a moment ago. Wheezing and whistling sounds, possible causes there would be allergies and bronchitis, emphysema, epiglottitis, and a whole number of different areas there, including problems with vocal cords, or an object stuck in the voice box or windpipe can cause some significant challenges. Move forward, some stridor, it's high-pitched sound. You see a number of different causes there. Feel free to pause the video if you wanted to look through each of those. Croup tends to be a very common one. Infection of the trachea and windpipe is in addition to epiglottitis. All can be a problem. And then again, you see foreign body airway obstruction come up with a number of these. So, we can't necessarily pinpoint one sound to one thing because some of these sounds may manifest with multiple conditions. So if we look at dyspnea, this difficulty breathing, subject feels subjective challenge to their breathing. And it may be caused by an increase in carbon dioxide or hypoxia, or often after high levels of exertion. And so, a patient may experience shortness of breath. Now, in some cases, that may be resolved by reducing the level of activity. An athlete sprinting down the field that pauses and feels very short of breath, stops, 20 seconds later, good to go, almost feeling 100%. And then we also have some problems that may not be, at rest, but maybe, or may not be during exercise, but paroxysmal nocturnal dyspnea would be a sudden and acute type of dyspnea that would be common in patients with left-sided congestive heart failure. And this can be a problem where during sleep, because of the positioning of the person's body, the fluid, because of this congestive heart failure, the fluid in the lungs may redistribute, leading to pulmonary edema, and unfortunately results in some difficulty with respiration to the point where a patient may actually wake up even gasping for air and maybe coughing to help to provide additional ventilation. And then we also have bullet 2 there would be severe dyspnea indicative of respiratory distress. And you can see that respiratory distress would be often accompanied by flaring of the nostrils and typically accessory respiratory muscle use. So they're labored breathing. Sometimes you can see, muscles in the neck as they're trying to pull up the rib cage, really engaging some of those sternocleidomastoid muscles. They're more labored here. This is not normal breathing. Examples, the intercostal retraction between the ribs are visible. So if you had the person take off their shirt and we start to look, they have a lot more activity of the muscles in that thorax region, aiding in some of the inhalation and exhalation. And then orthopnea, we are looking at shortness of breath that occurs when a person lies flat. And so this obviously might cause some problems during sleep. And so in some cases, patients with orthopnea may be aided with the sleeping in a seated position or a reclined position, in bed if they have a bed that can do some slight reclining, or sitting in a reclining chair. And oftentimes this particular orthopnea may occur as a result of or as caused by pulmonary congestion. And that may be as a result of heart failure, typically resulting from this fluid redistribution in that area. So a lot of different things may manifest, but certainly those are some of the key characteristics of dyspnea. Now, you obviously have a number of different conditions where you might be able to notice cyanosis, right? So if we're looking at somebody, we're physically looking at a bluish coloring of the skin and in some cases the mucous membranes that are obviously from deoxygenated blood. And it's obviously here a problem of unoxygenated hemoglobin in the blood resulting in inadequate oxygen delivery to the tissues. So typically it may develop most common, at least early in the stages of a problem in the peripheral areas. And so, commonly patients with cardiovascular conditions and respiratory diseases may be presented with cyanosis as a result of some of their challenges to the ability for, number one, the lungs to pull air in, that's ventilation. Number two, for the ability of gas exchange to occur, that's respiration. And number three, from the ability of the lungs, or excuse me, number three, the ability of the heart to pump and circulate that blood around. So if we have a challenge to any of those three, we may experience problems with cyanosis. And then we have pleural pain, right, which may be simply from inflammation or infection of the parietal pleura. That can obviously be a significant challenge and cause some increased discomfort from that inflammation. It may be, also occurring alongside coughing. So a patient that has an infection and has been coughing a lot may experience pleural pain. Friction rub can sometimes be heard with a soft sound that's produced by rough membranes moving against each other, as it sounds, a friction rub. And so sometimes as we're listening for those, it may be caused by pleural inflammation or other lobar pneumonia. In some cases, maybe even infarction or cell death of the lung tissue. Club digits, that's the fourth bullet there, resulting from chronic hypoxia associated with respiratory or cardiovascular diseases. Now, the clubbing is typically painless, but oftentimes occurs at the end of the digit. We'll see that occur, and it results basically from chronic hypoxia, and that chronic hypoxia causes some of this enlargement, referred to as club digits. And then changes in the arterial blood gases creates some challenge to a person, whether they're hypoxic and inadequate oxygen is available in the environment, maybe due to reduced partial pressure or due to reduced ventilation. And then you see the terms there, hypoxemia and hypercapnia, and so we might use these to refer to the level of oxygen or carbon dioxide. Hypocapnic would be reduced carbon dioxide, so it could go the opposite way, hyper or hypo. And if we're looking at this change that occurs in terms of hypoxia, it could be due to the number of red blood cells. Maybe we have somebody who's anemic. It could be due to the ability of the body to circulate the blood. And if it's not circulating back to the lungs where it's reoxygenated, that could cause some problems. So cardiac output from the heart to the lungs could be a challenge. Excessive release of oxygen. If we have the body, for whatever reason, drawing an abnormal amount and we're not able to reoxygenate at an adequate rate due to living at altitude or being at a higher environment where there's going to be a reduction in the transport rate, that could be due to an increase in tissue thickness. If we look at Henry's law or we look at Fick's law, we might understand that if there's a change in scar tissue or development of mucous membranes, that might all cause challenges in exchanging of gases. And so those can all be problematic. In addition, an increased carbon dioxide in the blood, we could have carbon monoxide. And carbon monoxide poisoning, which obviously, we're familiar if a person were to leave a car running and they were to go inside their house and that fumes from the vehicle went into the home, then a person would in theory be breathing carbon monoxide, which could unfortunately preferentially bind to the hemoglobin. So carbon monoxide would bind to the hemoglobin, but it doesn't let go. And the problem there is when it binds, it takes a spot of one of those 4 binding sites on hemoglobin, it takes a spot away from oxygen. So if we bind too many of these sites of oxygen, if we bind too many of these sites on the hemoglobin with carbon monoxide, there's not enough ability to carry and transport oxygen. So that could cause hypoxia because of the ability of a person to inadequately bind oxygen. So in those cases, sometimes high flow oxygen would be your best route of immediate treatment, and then getting them to a hospital perhaps with a hyperbaric chamber to increase the pressure to essentially force oxygen onto the hemoglobin and force carbon monoxide off. So a hyperbaric chamber may help in that regard. Same thing that you'd have when a person has nitrogen narcosis or the bends after deep sea diving, hyperbaric chamber to aid and assist with adding oxygen onto the body's red blood cells. And then I like this this table. Again, please feel free to pause the video so you can read this and go through it. But here's some basic therapies for respiratory disorders, including treatment, effect, and some examples. Okay, we'll shift here and talk about some infectious diseases. We'll kind of start with some of the upper respiratory tract and move into the lower respiratory tract infections. One of the things that I think we need to highlight is, recognizing that we have oftentimes very healthy athletes that we're working with. However, there's a risk of upper respiratory tract infection in athletes. And this risk may be due to the total exercise workload. And this figure represents the risk here of respiratory tract infection. Now, with a sedentary athlete, there just may be, just kind of an average risk of respiratory tract infection, but physical activity does have some benefit here, and a moderate load of total exercise may reduce some of our incidence of respiratory tract infection. However, if some is good, that doesn't always mean more is better. It's maybe, we'll give a caveat, more is better to a point, at which point we might find ourselves with very high levels of total exercise workload, resulting in increased above average risks of respiratory tract infection. So in this figure, it illustrates this J-shaped model. Now, I love this this figure because it very succinctly highlights epidemiologic and clinical research on the relationship between exercise and upper respiratory tract infection. And so we see in this figure an indication of obviously a variety of different subjects, and you'll notice that some of these subjects are running in longer duration events, marathons, elite orienteers, again looking at longer duration activities and marathon runners. And so the idea here is illustrating some of the incidence of upper respiratory tract infection among athletes who are engaged in higher levels of training in terms of mileage or distance or intensity. And so I want you to notice that if we look at the major findings from all of these articles, it's great because we have a list here of a bunch of different articles, and we kind of tend to see as we start to go through this a very similar trend. So just kind of looking at a couple of these. Upper respiratory tract infection incidence was twice as high in runners versus a control group after a 56-kilometer race. Orienteers with a 2.5 times higher upper respiratory tract infection compared to controls. Had 2.5 compared to the 1.7 in the control group. Now, if we look at number of kilometers per week, training 42 kilometers per week compared to 12 kilometers per week was associated with fewer upper respiratory tract infections in the lower quantity of work. And then here, upper respiratory tract infection incidence, a lot higher in runners compared to a control group. Runners, and that's probably, as we start to look at these, and you can go through these, I won't read through them all, but you start to look at these and say, it's probably these athletes are engaged in a high level of training leading up to these events. Now, in some cases, it may also depend on the location, because maybe what's happening in Los Angeles is a bunch of smog or a bunch of particulates from motor vehicles on the roadway that a person's now breathing in on a daily basis as they're going through. So the point here is just to illustrate that you think about upper respiratory tract infections as being a problem that obviously wouldn't happen in healthier individuals. But the reality is sometimes healthier individuals are engaged in high levels of activity, which may predispose them to a little bit of some of the challenge that may accompany increased ventilation. And so I encourage you to go find this article here from 2012, which was on managing respiratory problems in athletes. And on the next slide, I'm going to show you this very nice algorithm that kind of highlights some of that. So again, I'll let you read through the abstract there as you go through. So here we're presented with a very nice flow chart, and athletes who present with symptoms suggestive of exercise-induced bronchoconstriction. And so if we look at exercise-induced bronchoconstrictions, patients with those symptoms, we undergo some type of clinical assessment and baseline spirometry. We talked about spirometry early on in our lecture. Now, again, we also talked about this criteria, FEV1 to FVC. So again, now we see that come back into play. So was there some type of obstructive disease indicative? If no, or yes, we follow our flow charts, right? And then so if we didn't have some type of obstructive disease, we'd say no. So, bronchial provocation challenge, now they're going to go an additional test, and they try to illustrate now FEV1 to look at the changes that occur in FEV1. And again, if we follow this flow chart throughout, does the person present with symptoms supporting a diagnosis of exercise-induced bronchoconstriction? Right? If so, then we have to engage in some treatment. Maybe the treatment is non-pharmacologic. A nice warm-up, maybe putting something over the face to prevent inhalation of some of these particulate matter, dietary interventions, so trying to adjust some of the regulation, in addition to pharmacologic challenges, where SABA, short-acting beta-2 agonist, so now we're trying to provide some benefit to the areas within the lungs based on maybe an inhaler or other type of pharmacologic therapy. And if not, then maybe we have to consider a differential diagnosis. If it's not exercise-induced bronchoconstriction, is it exercise-induced laryngeal obstruction or some type of cardiac arrhythmia or another pulmonary disease, right? So consider additional investigation. So a lot of different methods here, but many of those from those diagnostic techniques from spirometry that I talked about early on. Now, we have a series of upper respiratory tract infections that a person may encounter or incur throughout their career as an athlete, including very common, the common cold, sinusitis or laryngotracheobronchitis, or exercise-induced laryngeal obstruction or vocal cord dysfunction, and perhaps epiglottitis. And so obviously the most common pathogen for the common cold, which might also be called or referred to as infectious rhinitis, would be rhinovirus. And it may also be adenovirus or parainfluenza virus. But a lot of times the problem with the common cold is that people say, well, shouldn't I be developing antibodies and shouldn't I not get the common cold ever again? Well, there are more than 200 possible causative organisms, so it's difficult for that person specifically to develop sufficient antibodies and immunity to avoid all colds. Now, we do know that the common cold is spread through typically respiratory droplets and secretions on the hands and contaminated objects, which then we'd go on to touch our face and other mucous membranes. So that's why it's so critically important to engage in hand washing and respiratory hygiene, and those are important in the prevention and symptomatic treatment of some of these common cold pathologies. So this particular infection with the common cold is very contagious because the virus tends to occur in large numbers in the infected area, the nasal mucosa, and unfortunately, this particular virus can survive for several hours outside the body. So somebody who's sick, who's in a room, touches their nose and then touches a doorknob, that could be on the doorknob when you then go to touch the doorknob. So it's always recommended during cold and flu season, have your athletes engage in healthy protective preventative steps in terms of hand hygiene, avoiding touching the face and the nose and the mouth to prevent as much as we can transmission or spread of the common cold. We have some signs and symptoms. Obviously, these are probably we're probably well aware of signs and symptoms of the common cold, but I suspect that many of us have, at some point or another, been sick. And so we obviously have a number of treatments for the common cold, including antiviral drugs, which may reduce some of the symptoms and duration, and some of our reduced risk to infect others. But sometimes it's a lot of just symptomatic supportive medication, to kind of alleviate some of the symptoms. Sometimes the common cold just has to run its course. But there are some complications of viral respiratory infection, and those can obviously create some challenges to different areas. So the virus can spread along continuous mucous membranes and invade certain areas. So could something like a viral infection here make its way into the ears and cause an ear infection or a sinus infection or bronchitis or pneumonia? Yeah, absolutely. And so that's one of those other things that we need to just kind of keep in mind, that something that tends to run its course in a normal case may end up with bacteria that sometimes makes its way to other areas and tends to proliferate. And now we find ourselves with secondary infections or a cold that didn't go away and manifest into greater problems. So treatment of the common cold, like I said, a lot of symptomatic treatment, kind of alleviating some of the symptoms, not necessarily combating and getting rid of the virus per se, but really just making the person a little bit more comfortable to reduce some of the fever and the onset of headache. And if the person does have some type of congestion, providing some expectorant or something where they're able to cough up some of the fluid that's around the lungs. Humidifiers, proper hand washing, these are all going to be very important in terms of our treatment. And of course, we have a couple other upper respiratory tract infections, including sinusitis, which is typically a bacterial infection. And oftentimes, as I mentioned, it may be actually secondary to the cold. And so something that may end up developing as a result of a common cold infection. It could also be due to an allergy in certain areas. And so, oftentimes this person may be put on a regimen or course of antibiotics, which can typically eradicate the infection. And then croup, very common viral infection in kids, 1 to 2 years of age, but really oftentimes we may see a range of 3 months to 3 years. And certainly with croup, this is where a person is going to have this larynx or subglottic area that becomes inflamed, and that inflammation can lead to this barking type cough, hoarse voice, or inspiratory stridor, and that's where we oftentimes see that characteristic croup sound. A lot of times this will just be self-limited, meaning that the child will typically just get better without treatment. Self-limited meaning that they'll typically have full recovery in a few days and won't need to necessarily undergo a round of medication or pharmacologic therapy. In some cases, if there is let's say, an exacerbation of the symptoms, which, cause smooth muscle spasm or some type of exacerbated obstruction, that may require additional medical treatment. And so if it's not something that resolves, we're encroaching on a week here, that's definitely something we need to get referred out. So here's a nice general comparison of respiratory infections, and you see 3 different respiratory infections in the blue across the top of the screen, and then obviously who is impacted by each of those and what that looks like in terms of the cause, the pathology, the onset, and the signs. So again, feel free to pause the video if you wanted to look into this figure, or excuse me, table a little further. Okay, we might end up with infection of the epiglottis and swelling of the larynx, and that might cause some challenges for a patient who's in the younger age category, maybe 3 to 7 years. Oftentimes there may be a rapid onset, and so a fever and sore throat kind of develop and come on quickly. And the child may sit in this tripod position. I recognize that may not necessarily be the characteristic child that we're familiar with, but great figure to illustrate what that patient may look like in an effort to aid in getting air in and out of the body. Sometimes the challenge to ventilation can be accompanied with increased anxiety, and so sometimes treatment includes asking the patient to kind of just relax, kind of regulate their breathing. Getting worked up is only going to tend to exacerbate the condition. The person experiences difficulty breathing, they get anxious and worried, which makes the difficulty breathing a little bit worse, which means they get more worried, which means the breathing gets worse, which means they get worried. So sometimes encouraging some of this relaxation in terms of the fear, and kind of helping the patient to recognize that slowing the ventilation is going to be the most helpful in this case. Now, in addition, we can also treat with high flow oxygen or oxygen via nasal cannula, especially if it's something that's not critical in terms of oxygenation, but maybe just providing a little bit of oxygenation, asking them to slow their breathing, breathe in through the nose, 2, 3, 4 liters per minute of air. Low flow oxygen may be all that's necessary in this case. So, kind of treat each patient and look at the need in that case. And of course, influenza, which we're all familiar with. Now, the flu differs from the common cold. We talked about the common cold, but the flu differs in that usually it has a sudden acute onset. And that sudden acute onset, I'm thinking to myself, getting the flu, you get that fever and marked fatigue and aching pains. You just feel lousy. It's difficult to maybe even walk up a flight of stairs. And it comes on so fast, right? But, it can manifest from flu into more serious conditions like pneumonia. So a mild case of influenza can be complicated by secondary problems. And of course, most deaths during flu epidemics result from pneumonia that develops as a result of the originating flu. So we might, in some cases, be prescribed some medication to alleviate some of the symptoms of the flu, and antiviral drugs and prevention like respiratory hygiene, avoiding coughing on each other, coughing into your elbow, encouraging a patient with the flu to avoid spreading it. Certainly vaccinations recommended for most individuals in terms of preventing that, but sometimes the vaccinations that you get, obviously they're created based on a model that was anticipated. And sometimes the vaccine is found to be less effective at a given strain that ends up, taking over during flu season. So vaccinations help, but, sometimes they're not 100% effective. So we'll need to be aware of that. And then moving from upper now to lower respiratory infections, you see bronchiolitis and pneumonia and severe acute respiratory syndrome, or SARS. Your textbook also addresses tuberculosis and some other conditions as well, and so I encourage you to dive into that for some supplemental reading. Now, bronchiolitis, we're looking at an infection, this myxovirus, that's typically caused by some type of respiratory virus, and you see there respiratory syncytial virus. That's another example what may cause bronchiolitis. This general feeling of discomfort and illness, that overall malaise, but also wheezing and dyspnea, rapid shallow respirations and cough. If we're listening to lung sounds, we may hear rowels. So treatment, is going to be supportive and symptomatic. So monitoring blood gases in severe cases, ensuring that oxygen levels are adequate, making sure that the patient, if they need oxygen, is provided it, but monitoring some of our signs and symptoms here. So virus causes necrosis and inflammation of the small bronchi, which again creates some challenges sometimes to ventilation, including, as we see on the figure here, mucus building up and inflammation of the tissue. So there may be some challenges to movement of the air, causing some of those chest sounds that we talked about a moment ago, and also initiating a cough for that irritated tissue. Pneumonia, which may develop secondary to other respiratory conditions like we have already discussed, being caused by viral, bacterial, fungal agents, and anatomical location of the infection, looking at this occurring throughout both lungs. But it may also be just something that consolidates in one particular area. So pneumonia is obviously a risk following aspiration or inflammation in the lung, and so keeping an eye on a patient who is sick that doesn't develop into something worse. So those can obviously be problems, but most of the time they're typically lung related, but occasionally the infection that a person gets is bloodborne and then develops into pneumonia. So that, again, from other areas, that can cause some challenges. And there are 3 types of pneumonia that we'll see highlighted here in terms of lobar and bronchopneumonia, and then this interstitial pneumonia as well. And so you can see there the distribution, cause, pathophysiology, onset, and signs of each. I'll let you pause the video to read through that. And of course, we have these different types of pneumonia, which here are very well illustrated in this figure, and that's why I like this figure. So based on that previous slide that you read, if you look at kind of how this may manifest or where that may look, bronchopneumonia, obviously we have the trachea and then the bronchi, and certainly our primary bronchi are then splitting into these finger projections, and of course developing this more diffuse bacteria kind of circulating throughout. Lobar pneumonia, where we have pneumonia consolidation of bacteria into a particular area, often congregating or consolidating into a specific area and taking over the entire lobe. Remember, we have 2 and 3 lobes of our left and right lung. And then looking at number 3 here, this atypical pneumonia and mycoplasma, looking at how that would be this viral infection that may, again, begin to spread. In this bacterial pneumonia, we may have some development of, in some cases, resulting from streptococcus pneumonia, and this infection that can localize on 1 or more lungs, often may be associated with rust-colored sputum in a patient with pneumonia. That may indicate streptococcus pneumonia as the infecting agent. And so again, asking about sputum, have you been coughing anything up? Have you looked and seen, is it clear? Is it yellowish? Is it rust-colored? So with lobar pneumonia, the first stage in its development is typically this congestion, which is often from inflammation, and oftentimes in the alveolar wall. And that's when we start to develop some additional mucus and that rusty sputum and that exudate that develops as a result, oftentimes forms in the alveoli. Well, as we understand, an increase in tissue thickness as a result of an increase in junk around or surrounding or inside the alveoli, that interferes with oxygen diffusion and gas exchange. So as that's the first stage of development, and then next we have these neutrophils that are going to accumulate in the alveolar exudate and that mucus, and they form maybe a solid mass in the lobe, which is called consolidation. And that presence of this congregation of neutrophils and red blood cells and sometimes fibrin in this exudate provides or produces this rusty sputum color. Right? And that's what's characteristic of lobar pneumonia. Now, eventually, the person gets better, the red blood cells break down, the infection resolves, and then, of course, as you may recall, macrophages come to the site to initiate some of the breakdown and allow it to be coughed up and removed from the body. So a lot of these are here occurring in lobar pneumonia. And the infection could spread to the pleural cavity, and that can cause empyema. And if not quickly resolved, that empyema can cause adhesions between pleural membranes, which cause pain and difficulty with ventilation and breathing. So, this can obviously manifest and continue, so it's important that if a patient presents initially with a cold that doesn't resolve and now they have some respiratory and lung and chest discomfort, they need to get checked out. Do they have some type of developed pneumonia that needs to be treated? We've talked about some of those manifestations here, but often sudden onset, symptomatic with high fever and chills, fatigue, difficulty breathing, pleural pain, as we discussed some of the rationale there. The figure off to the right illustrates the respiratory secretions containing this gram positive component, and then histology on the lower slide looking at bronchopneumonia, which we'll have more information on the next slide. So here's our bronchopneumonia, and note the figure there which has the arrows. Those are the areas of consolidation, and sometimes these areas of consolidations may appear as pus-filled bronchi. So now we have this junk. Exudate would be, as I've mentioned, exudate before, but it's this developed fluid in the lungs. Sometimes mucus and other stuff that is going to congregate in that area. And so, here we have this insidious disease that just comes on slowly, doesn't really have this known cause, diffuse pattern of infection, several species of microorganisms may be the cause. So, we have this challenge here, but antibacterial treatment is going to help to reduce some of the inflammation that's developed. And certainly, if we have that fluid developing in the lungs, and obviously we need to get some maybe expectorant to be coughing that out, but it's going to interfere with gas and oxygen diffusion. So if you have your athlete that's engaged in high levels of activity, probably not as much with this particular ailment because of the challenge to respiration. And Legionnaire's disease, typically this particular ailment found in the pulmonary macrophages, and Legionnaire's is a gram-negative bacterium, so something that can be identified on some staining. So gram-negative bacteria have a cell wall structure that's unable to retain this violet dye, and so gram-negative, typically, where we have gram-negative bacteria, are pathogens that have a characteristic outer membrane of the cell wall resistant to the dye. So something that, as we do some type of collection of the sample and analysis in staining, helps to maybe identify what the disease could possibly be. So obviously a pneumonia here, and challenging to identify, but as I talked about the culture medium and how we may be able to go about that. Now, untreated infections cause severe congestion and pulmonary consolidation, as we've talked about in a moments ago with consolidation specifically. But then also here we can have problems with necrosis in the lung and destruction of some of the tissue. And certainly this can be possibly fatal. So something that needs to get identified and looked at. And SARS, this acute respiratory infection, Oftentimes with this, the incubation period here is somewhere between 2 days to 7 days, and oftentimes it's more in the latter side of that, so 4 to 6 days. But the first stage here, the person is going to present with flu-like symptoms, fever, headache, chills. Now they might also have an onset here of diarrhea, which may last for up to a week. And the effects on the lung are evident several days later because the person now has this marked dry cough and challenge to breathing. And so the later signs, when we look at this dry cough and difficulty breathing, may have some areas of interstitial congestion. Mechanical ventilation may be required for some patients, and so a chest radiograph may be helpful. And even a chest radiograph by day 7 may already indicate the spreading of certain patchy areas of this congestion, which may be obviously the cause of the difficulty breathing and mechanical ventilation that may be required. So some of the treatments here, in this particular SARS ailment, the case fatality rate is pretty high. Maybe somewhere around 10-20%, but if a patient is older or has pre-existing conditions, we could see that rate increasing up to 50%. Of some of the patients that attain SARS, if they're older or have some type of condition that is already compromising their immune system. So the challenge here is obviously with diagnostic testing, which may be difficult in some cases to kind of quickly illustrate antibodies, because the antibodies may not be present for a period of 3 weeks. So if we're trying to look for this disease and we're saying, okay, let's check for antibodies to see, obviously what is the body creating to fight this infection, the antibodies may not be present until 3 weeks after the onset of some of the symptoms, which may not occur for, a couple days, 2 to 7 days after they develop the pathogen. So problem here is the non-specific early manifestation looks a lot like the flu, and so it makes identification immediately very challenging. So that's one of the risks here of severe acute respiratory syndrome. Now, exercise-induced laryngeal obstruction, which was formerly referred to as vocal cord dysfunction, is one of the primary imitators of asthma and exercise-induced asthma. And so commonly it's misdiagnosed because oftentimes we may think that a person has asthma or something more serious when really it's just this exercise-induced laryngeal obstruction. Now, it's inappropriately treated with bronchodilator because, again, it's not the bronchi that's the issue, it's laryngeal obstruction. So bronchoconstriction and airway inflammation are not the primary cause of this dyspnea. So that particular pharmacotherapeutic intervention isn't going to help patients because the disruption is not with the bronchi, but rather with the larynx, vocal cord, right? So the average time to correctly diagnose exercise-induced laryngeal obstruction after the onset of symptoms may actually be 4.5 years, according to some research, because oftentimes a patient's thought to have asthma or thought to have some other type of respiratory issue, and it may be that it only happens when a person engages in physical activity, and that may only be here and there if they're a sedentary participant. So it may take a while for this to get diagnosed. But what's unique about this particular ailment is that it's characterized by abnormal closure of the supraglottic and glottic level of the larynx, generally during inspiration, causing resistive airflow associated with shortness of breath and difficulty breathing. So a little bit about the epidemiology here is that it may be present in nearly 5% of the athletic population. So this objective diagnosis of exercise-induced laryngeal obstruction is best achieved through direct visualization of the larynx. And so direct visualization of the larynx during exercise is sometimes challenging, which is why we have to get the proper clinician involved, because patients with this exercise-induced laryngeal obstruction may be asymptomatic at rest. So if we look at the larynx or try to identify the pathology at rest, we don't see anything. And that's why that time frame for diagnosis is so long, because there's oftentimes not a quick determination. It requires a little bit of challenging diagnosis. For instance, continuous laryngeal endoscopy during exercise, so that we have uninterrupted visualization of the larynx. And it has to be uninterrupted visualization while the patient is symptomatic, which may or may not occur all the time depending on the athlete. So obviously some challenges here, but certainly understanding and recognizing some of those symptoms that you see on the screen, and referring obviously to a physician for spirometry testing to determine whether or not it's asthma or something like this. And then I've already addressed some of the treatment, but the most common treatment approach has included diaphragmatic breathing control and laryngeal exercise performance under the guidance of a speech and language pathologist. So trying to prevent some of the laryngeal obstruction by strengthening some of the vocal cord muscles, and so that when the athlete engages in physical activity, they don't have that supraglottic airway obstruction. So some patients experience these laryngeal muscle strengthening and control, such as speech therapy, psychotherapy, hypnosis, biofeedback. Different techniques for respiratory muscle training may also be useful, but require obviously additional and continued research. And again, I encourage you to take a look at this research article, open access, so something that you can go out and look at and read. But this is eukapnic voluntary hypernia and exercise-induced vocal cord dysfunction, and addressing some of the challenges in athletes, especially with trying to identify various types of glottic and supraglottic obstructions. And so this article is something that might be of benefit or of interest, and so I encourage you to go out and take a look. Well, we've highlighted some of the other areas like asthma and COPD, and how those may manifest as some other things, including exercise-induced bronchoconstriction or laryngeal obstruction. But really, if we look at asthma, it's characterized into two categories, either extrinsic or intrinsic. So extrinsic would be acute episodes that are triggered by type 1 hypersensitivity reactions, where we have some type of inflammation or inflammatory agent that impacts the lungs. Right? And then we have intrinsic, which typically is hyperresponsive tissue inside the airway, which initiates the attack. So rather than something from outside the body coming in and causing inflammation, intrinsic asthma is a hyperresponsive attack from within. So stimuli would maybe be as a result of other respiratory infections, stress, exposure to cold, but could also have an intrinsic asthma attack from inhalation of certain irritants, which cause the intrinsic asthma that we see. And so this figure here illustrating the edema or swelling of the mucous membrane, and that swelling of the mucous membrane alongside this mucus plug causing some of this challenge and bronchospasm, resulting in a narrowed airway. Now, obviously, a narrowed airway is going to create a significant challenge to flow of air. So we obviously examine the pathophysiologic changes of the bronchi and the bronchioles in that case, and accompanying the inflammation of the mucosa with the swelling is CD4 lymphocytes. Okay, those are believed to promote inflammation by the eosinophils and mast cells that we've already been introduced to up to this point in the course. And bronchoconstriction, which occurs and is caused by contraction of smooth muscle, which is why some type of therapeutic measure may be an asthma inhaler or a medicated dose inhaler. So if we had a patient who experienced this bronchoconstriction and they were given an inhaler, we could have some type of block of the beta cell to allow for the lung to open up. And then obviously changes create obstructed airways either partial or total, and may indicate or challenge the breathing, to some small degree or to a large degree. Now, if we look at causes, we've already seen a number of these, so I'm gonna move quickly past this slide. You can kind of quickly read through those, but some of those we've already looked at. But obviously, exposure to some of these in an asthmatic patient may exacerbate some of their asthmatic response. And of course, that response would include coughing and difficulty breathing, as well as a feeling of tightness in the chest. If you're listening to the lungs, we might hear episodic wheezing. And of course, if we're observing the patient, maybe rapid and labored breathing, and in some cases, expulsion of thick or sticky mucus. Tachycardia could result. Hypoxia certainly could be representative. And as a result of rapid breathing, we could end up with respiratory alkalosis as a result or cause of quickly ventilating and blowing off the CO2, which is going to create a more alkaline environment. In other areas of the lungs, we might end up with, because of the air that's trapped there and not able to get out, we might end up with respiratory acidosis in certain regions of the lung and the alveoli. So, there may be some challenges where we're ventilating rapidly, but some areas of the lung aren't actually getting any of that air, and so they become acidic, whereas the rest of the body may become more alkaline. And a person that has this challenge, hypoventilation leads to hypoxemia and respiratory acidosis. So if their challenge is resulting in decreased ventilation and decreased breathing, that can obviously result in respiratory failure and a decreased responsiveness and cyanosis as a result. So in some cases, it may be necessary for an athlete who has asthma to undergo testing during exercise, because maybe their asthma is most highlighted or is most noted during physical activity, in which case they may have exercise-induced asthma or exercise-induced bronchospasm, where they don't have this ailment at rest, but they do when participating in levels of physical activity. And in some cases, it may only be during levels of activity in areas where there are irritants, like a cold environment. And I specifically say irritants like a cold environment because typically cold air doesn't hold as much water, so it's typically drier. Areas like downtown streets of Chicago or LA, where there's a lot of traffic and a lot of pollution. So exercise-induced bronchospasm may occur in greater than 50% of patients with asthma, and so it's important to recognize whether or not this particular ailment is indicated. And the typical response here, initial bronchodilation during the first 10 minutes, but then it's this progressive bronchospasm that occurs after exercise. So we're aware that there may be some challenges during exercise for an asthmatic, but could the problem be post-exercise after the person stops? So again, if we got a patient that has some type of breathing difficulty or breathing challenge and they are prescribed an inhaler, you need to make sure that this athlete has their inhaler with them, or that you have access to the inhaler to help administer the medication should a patient experience a challenge during or after physical activity. And of course, we have an acute episode and what that might look like in terms of a severe attack, and certainly general measures in terms of treatment, and looking at avoiding triggering factors, good ventilation of the environment, engaged in different types of activities, swimming and walking, and of course, measures for acute attacks, so controlled breathing techniques and inhalers, and of course, glucocorticoids may be of assistance. And of course, there may be a need for hospital care if there's no response to a bronchodilator and no response to a medicated dose inhaler. And prophylaxis and treatments of chronic asthma could end up with some type of treatment. And you see a couple of those on the screen and how those may be effective in preventing an asthma attack. And of course, we have COPD and other restrictive lung diseases that may come up, and many times we may not see some of these in a younger population, but a population that smoked all their life and now they're in their late 40s may end up seeing some of these manifest depending on the health of the person throughout their earlier years. So chronic obstructive pulmonary disease is a group of these chronic respiratory disorders, and it causes irreversible and progressive damage to the lungs. This debilitating condition affects a person's ability to work. And it can lead to the development of cor pulmonale, which is this abnormal enlargement of the right side of the heart, namely the right ventricle. And on an ECG, we look at P pulmonale, and you have this symptomatic cor pulmonale, right? So we might see some other manifestations, including respiratory failure, that may occur as a result of an obstructive lung disease. And on the screen here, you see emphysema and chronic bronchitis, and of course, asthma. And I encourage you to stop the video so you can quickly examine some of the difference in etiology and pathophysiology, as well as some of the other characteristics which we may expect to see in terms of sputum and cyanosis and infections. Now, emphysema is, again, one of these things that we often associate with smoking and damage to the lung tissue over a period of time. And so damage to the alveolar walls and other areas of the septae may lead to, unfortunately, these areas of the alveolar spaces which remain overinflated, and unfortunately contribute to some factors which, maybe as a result of genetic deficiency or genetic tendency, as I mentioned, cigarette smoking, other pathogenic bacteria, and certainly if we now analyze some of the challenge in spirometry, may be able to identify some of the onset early if we're getting into the physician's office and actually doing some of this testing. And of course, we've discussed some of the breakdown of the alveolar wall, creating some significant challenge to respiration. Obviously, if you're losing pulmonary capillaries and you're losing some of the surface area for gas exchange to occur, Fick's law and Henry's law gives us an indication that the rate of gas exchange is going to be dramatically reduced as a result. Certainly fibrosis comes into play when we talk about the narrowing of airways and weakened walls, and this discussion of passive expiratory airflow. So now we might have a patient who's more labored in breathing, having to really engage some of their respiratory muscles, even at rest. And so there might be some challenge, especially as we see this progressive difficulty with expiration. So what I kind of transition to this slide is that trapping of air and the increased residual volume that results may be caused by this loss of elasticity and an increase in residual volume resulting in this overinflated lung. And as a result, we now have some additional challenges where now we might see a flattened diaphragm on a radiograph. And a patient may actually present, when you look at them, with a barrel chest because of the fixation of the ribs in this respiratory position and this increased enteroposterior diameter. Because of the loss of elasticity, they have to engage these extra accessory muscles to help ventilate. And so that's why we may have an overdevelopment of some of these lungs and appear with this patient who's barrel chested as a result of, again, some of this additional inflation of the alveoli. Now, advanced emphysema and loss of tissue leads to a number of different challenges, certainly including pneumothorax and hypercapnia and hypoxia. And unfortunately, we may have some challenges with pulmonary hypertension, cor pulmonale, as previously discussed, which may develop in the late stage of emphysema. Now, we might be on the lookout for difficulty in breathing and in some cases hyperventilation with, again, because of that change in the elasticity of alveoli, we might be observing prolonged expiratory phase yielding and resulting in development of barrel chest as a result. And again, anorexia and fatigue, clubbed fingers, may be characteristic in this regard. Obstructive sleep apnea, again, this may be identified by loud snoring with intermittent gasps for air. And sometimes a patient may not be aware that they have this, but oftentimes, if they're sleeping with another partner in the same room or in the same bed, their partner may identify the changes in respiration or in ventilation at night. And in some cases, the patient may be awoken due to some of the changes in ventilation, and they may experience maybe poor quality of sleep. So sleep apnea results when the pharyngeal tissue collapses during sleep, and it's that which causes a repeated and momentary stop in this breathing or cessation of breathing. Men are often affected more than women, and predisposing factors include obesity and older age. Now, if you're familiar with somebody who's had in their life been diagnosed with obstructive sleep apnea, you may be aware that they may have complications from sleep apnea directly related to type 2 diabetes or pulmonary hypertension or right side congestive heart failure or if previous cerebrovascular accident. So all of these may see challenges, right, that come into play, not only from sleep apnea, but from other conditions. And the treatment may incur continuous positive airway pressure pump, or a CPAP. And the CPAP machine delivers humidified room air at a pressure that's going to maintain an open airway and prevent that momentary cessation of breathing, which is characteristic of obstructive sleep apnea. Some cases, a patient may, instead of using a CPAP machine, may use some type of oral appliance, which acts to move the jaw forward, for instance, to reduce the collapse of the pharyngeal tissues. Or there may be some other devices which change the patient's position while they sleep to prevent the patient from sleeping in a supine position, which often predisposes apnea. And so there may be some other devices or effective areas which may be important. Now, some restrictive lung disorders would be impaired lung expansion and reduced lung capacity. And so some challenges there would be abnormal chest wall movement, impairing lung expansion, like kyphosis or scoliosis that we may be familiar with, and then diseases affecting the supporting framework of the lungs, like idiopathic pulmonary fibrosis, may be some challenges which result in restrictive lung disorders. We'll move into briefly some vascular disorders and looking at pulmonary edema and pulmonary embolus. So pulmonary edema is a swelling or fluid that collects typically in the alveoli and also the interstitial area within the lungs. And unfortunately, it can result from many primary conditions, and it can be secondary to other infections and other diseases. So it may be something that results as a secondary manifestation of another pathology. But what's characteristic of pulmonary edema and that swelling and fluid that collects in the alveoli is that it reduces the amount of oxygen diffusing into the blood. Now, that diffusion of oxygen, because of that increased barrier, decreases the rate of diffusion and unfortunately results in some cases, some challenge to respiration, resulting in reduced oxygen saturation levels, and could result in some other more problematic issues should that not be resolved or at least regulated. Pulmonary edema may also develop again with inflammation in the lungs, and plasma protein levels are low, and with pulmonary hypertension we might also see a development of pulmonary edema. So pulmonary edema has also the tendency to develop during exercise, and that would again be referred to as exercise-induced pulmonary edema. So exercise-induced pulmonary edema is most commonly reported in divers and swimmers, and occasionally it's also reported in association with other non-immersive sports. Again, those activities which are longer in duration or more in terms of the level of intensity for long periods of time. Now, with pulmonary edema, there may be some other factors that are detrimental to cardiac loading. And so, for instance, cold water exposure, wearing a wetsuit, excessive hydration before swimming can create some significant challenges to the cardiovascular system. Pre-existing hypertension also creates a challenge. So if we talk about not only does the heart have to pump blood throughout the body, but if now we encounter pulmonary edema and swelling in the lungs, creating challenge with vascular respiration, that can cause some significant disruption to a person's ability to perform high levels of physical activity. And so in this case, we see the cause or initiation of pulmonary edema resulting from, number one, this high hydrostatic pressure resulting in interstitial edema. And then, of course, this fluid, which then makes its way into the alveoli. And of course, because of this increased barrier of tissue transport, now we have a reduction in oxygen diffusion. And fluid dilutes surfactant, and if we recall our discussion of surfactant being this fluid which allows for easier ventilation or opening of the alveoli, all of these resulting in potential for hypoxemia. So some things to look at in a patient with pulmonary edema might be a cough, an orthopnea, and rales for listening to lung sounds. Certainly with increased congestion, we may actually see hemoptysis, which we talked about earlier, in terms of that pink and frothy type sputum. Breathing becomes more difficult. Hypoxia increases, cyanosis develops. So now we have some significant challenges which are going to manifest. So we might have to treat some of the causative factors. So what was it that's causing the onset of pulmonary edema? So treating the edema may not be helpful, but rather treating the infection causing edema, that may be more relevant. Now, in that time that we're treating the cause, we're also looking at supportive care, whether a person has to have oxygen therapy or some other type of expectorant to help to clear some of this mucus that's developing, possibly also including positive pressure mechanical ventilation if there's a really large obstruction of some of the alveolar ventilation or a large difficulty to alveolar ventilation. Similar to pulmonary edema, but rather now we're looking at an embolus. So instead of fluid that develops in the lungs, now let's look at the vasculature. So now within the pulmonary circuit, if we're not now talking about fluid inside of the alveoli, now we're looking at a blood clot or a mass that circulates throughout the body, makes its way to the lungs, and now gets lodged in a pulmonary artery or one of its branches within the network and facilitates a reduction of blood flow to the area of the distal lung tissue. So oftentimes we might see a pulmonary embolism developing, and it's that last bullet down here, from or originating from a deep vein thrombosis. And in some case that may be due to a patient who's recently had surgery, for instance, a hip surgery, where now they have significant repair to that area, and there could be a clot that develops at the source of the surgical site, and that clot then breaks off, makes its way into the bloodstream, circulates throughout the body, and gets stuck in the lung. So depending on the size of the embolus, if it's a small pulmonary emboli, it may not be relatively noticeable because, again, if it's a very small embolus, it's only obstructing a small amount of lung tissue. Whereas a large emboli may end up causing a significant reduction in blood flow to areas of the lung, resulting in sudden death. So again, we have, let's say, a patient who's recently had surgery, and they have this embolus which breaks off from the vein in the lung, makes its way in through the inferior vena cava into this right atrium and into the right ventricle, and again it travels around, of course, making its way into the lung. Now, if it's a small clot, the single small embolus may be silent or relatively unnoticed, but multiple small emboli may cause larger areas of tissue to be obstructed. Of course, if it wasn't a small emboli affecting just a single amount of tissue, but rather it was a larger embolus, that might affect all the distal tissue from the area in this vascular network. Very large emboli block all pulmonary circulation and can lead to immediate shock and cardiac arrest. Okay, so large emboli cause decreased blood returning to the pulmonary vein, and that's going to cause decreased cardiac output, decreased blood flow to the brain, and not enough oxygen to the brain results in cell death and problems, as we've indicated before. So I've already talked about small and large emboli, and on the screen you can see some of their signs and symptoms. And of course, the massive emboli, where we really have a large degree of vascular tissue or vascular network being occluded, resulting in severe crushing chest pain, low blood pressure, rapid weak pulse, and loss of consciousness, leading to and perhaps resulting in death. So one of the things that we can do with the pulmonary emboli is to prevent it from occurring. So if a patient has some type of vascular disorder, they may be given these anti-embolytic socks. So sometimes you've seen people wearing compression leggings or compression socks. That's again to prevent some pooling of blood. Let's say a patient with varicose veins. So this compression sock prevents pooling of the blood in the distal circuit, hopefully then preventing a development of a clot, which could then circulate and make its way to the lung. Again, health teaching prior to surgery, I kind of skipped over that one, but that would be from that patient that's had surgery, indicating that they do need to remain, active in some cases, participate in the rehabilitation therapy to prevent some of the clot development or moving. And then certainly exercise to prevent thrombosis and use of anticoagulant drugs to prevent the development of a clot in general. So again, a diagnosis looking at the radiography of the lung tissue, scanning the lung, MRI, sometimes in some cases a pulmonary angiography may be necessary to identify a clot. We've talked about angiography with illustration or looking at vascular ultrasound and then looking at the vascular tissue that's being perfused as there's a bolus of this maybe colored dye injected into the tissue, for instance. We also have treatment, so assessing risk factors and prolonging bed rest and compression stockings depending on the surgery that's just happened. Certainly surgically inserted filter into the vena cava to filter if a person has a lot of clots that they're circulating throughout the body. This filter is going to stop them from getting into the heart. Heparin or other type of streptokinase, which is this enzyme produced by some streptococci that's involved in breaking down red blood cells, could be used in the treatment of inflammation and blood clots. Embolectomy could be another option, and that would be the emergency surgical removal of emboli, which are blocking blood circulation. So getting in and removing those problems could be necessary. And then we have some expansion disorders like atelectasis and pleural effusion and pneumothorax. Certainly, you could go into your text and read about flail chest and infant respiratory distress syndrome and acute respiratory failure. But I want to start with atelectasis, looking at this overall decrease in breath sounds on whatever affected side where a condition of non-aeration or collapse of the lung has occurred. And oftentimes it may be associated with airway obstruction. And so we might be concerned about this particular condition leading to a decrease in gas exchange and hypoxia. And so in this area where we have non-aeration, obviously alveoli are airless, and so they may collapse and inflation or atrophy may occur. And so with a patient here with atelectasis, ventilation and perfusion are going to be altered, and we're going to have some challenge and dysfunction in that regard. So mechanisms that can result in this condition would be something along the lines of obstructive or resorption, and where we have total airway obstruction, where we have compression atelectasis, like some other outside mass or tumor that's pressing on a part of the lung to essentially cause it to compress and collapse. increased surface tension in the alveoli, which is going to prevent the expansion of the lung. That may be caused, if we have a reduction in surfactant or other, substances to help to reduce surface tension. Fibrotic tissue, fibrotic tissue in the lungs or pleura, which can also cause restriction and expansion. And postoperative atelectasis could be caused after surgery. And so essentially here we have this occur from a block, and unfortunately due to this blockage in airflow, we have airflow blockage, which results in the remaining air to diffuse into the tissues. It's not replaced, and it results in this collapse as a result. So the total obstruction of the airway, where the air is absorbed from the alveoli distal to the obstruction, is characteristic of this condition. So if we look at some of the signs and symptoms, obviously those being dyspnea, difficulty breathing, challenges and changes in a person's oxygen status. And so if we look at pulse oximetry, we might find that there's also changes that are occurring in red blood cell carrying oxygen capacity. Large areas of this might result in difficulty breathing and increased heat and respiratory rates and chest pain in some instances. So result here may incur surgery, and following surgery, deep breathing exercises, body position changes, forced coughing to kind of aid in some of the reperfusion of some of these areas. Caused by, in some cases, external pressure. So if it was caused by a cancer or a mass or a tumor, if we can remove that, that's going to be a treatment that's going to be helpful. Or if it was a blockage, we can remove the blockage, and that's going to again aid in reperfusing the area of lung that was dramatically impacted. And pleural effusion, okay. Now instead of this swelling, we now have this presence of excessive fluid. So pleural effusion is, instead of within the lung and inside the alveoli, now we're talking about the pleural lining. And so we could have pleural effusion where this lining of the lung has excessive fluid now developing in the pleural cavity. So a little bit different than pleural edema, and a little bit different than pulmonary embolism. Now we have this fluid that's going to surround the lung. And here now we have an increased pressure that's on the lung tissue, resulting in challenge to ventilation. And we could have this occur in response to inflammation. And if we had development of fluids like in the cavity around the lung, that unfortunately is going to result in increased hydrostatic pressure and decreased osmotic pressure of the blood vessels. So now we're going to have a challenge to not only the ventilation and respiration, but also to perhaps movement of blood and circulation throughout the body. So this can develop and manifest into pretty dramatic problems if not resolved. So we'll start with dyspnea and chest pain, increased respiratory and heart rates, and usually dullness to percussion, an absence of breath sounds over the affected area could be resulting. So if we're listening for lung sounds, be sure to listen for that. And then tracheal deviation could be a significant problem, because if we have tracheal deviation, it means there's a significant pressure that's developed in one side of the chest cavity, and that's caused a shift toward the unaffected side. So all that pressure that's developed as a result of this fluid around the lung has essentially shifted the lung to one side, and we have a tracheal deviation and corresponding hypotension result. So what would we do? Well, we can remove the underlying cause that's creating the excess fluid, and of course that may be taking a sample of the fluid to analyze to confirm the cause, and then engage in that. Pericardial synthesis would be removement of fluid around the heart. So pericardial, so we could have pleural synthesis where we remove fluid around the lung. And so if we have chest drainage or thoracocentesis, removement of fluid around the thorax and the area in the chest cavity, obviously that's going to relieve some of the pressure, kind of reduce some of the ailment pressure that's placed on some of those, and prevent some of the challenge that a patient was experiencing. Then we also have pneumothorax, and this would be where air gets into the pleural cavity and causes a collapse of the lung due to air getting into the pleural cavity. So, talked about a lot of different things here of fluids and lungs and swelling and blockages, but now pneumothorax is where air makes its way into the pleural cavity and causes essentially collapsing of the lung. So air can enter the pleural cavity from internal airways, where we have maybe a rupture of the lung, allowing air to leak from the lung into the chest cavity, ultimately causing this compression of lung tissue. And it could be due to trauma. We could have simple or spontaneous pneumothorax or secondary pneumothorax, which may be associated with an underlying respiratory disease. So problem here is where so much air leaks into the thoracic cavity that it starts now to compress the lung. And if the lung tissue is compressed, we can no longer ventilate. And if we can no longer ventilate, we no longer inflate alveoli. We therefore no longer have gas exchange occurring in those areas. So the incidence of pneumothorax in athletes, young, tall individuals are susceptible to the development of primary spontaneous pneumothorax. Could particularly occur, as I mentioned, with areas of high contact sports and trauma, where contact athletic activities have been associated with direct development due to running into another player, due to contact with the implement like a stick or a ball. Athletes, in some cases, may not present with classic clinical symptoms, but they may experience this atypical chest pain that's attributed to injury. So keep an eye on that, and whether or not there's been some type of trauma that was incurred. And obviously looking at lung sounds is going to be important in this area. Not hearing lung sounds is certainly going to be problematic and something that's going to be need to be referred up. Now, of course, different types of pneumothorax, which you may or may not already be aware of, but as the tracheal deviation occurs, that would be a tension pneumothorax, certainly a possibility. I mentioned closed pneumothorax, where we have some type of rupture of the lung inside the chest cavity, and that air leaks from the lung into the chest cavity. But we also have an open pneumothorax, where perhaps there's, let's say, a penetration of the chest cavity, whether it's a stabbing, like a knife entry into the chest cavity, and now air is leaking into that chest cavity, or there's a bullet wound or some type of outside penetration through the chest cavity, resulting in air getting inside the body, inside the chest cavity. So certainly you can look at the cause, the air entry, the effects, and the signs here of this table. So I've kind of already discussed the open pneumothorax, and that was where we have some type of atmospheric air that enters into the pleural cavity. Again, like a knife injury or a gunshot wound would be primary examples, but oftentimes you'll experience and observe a sucking chest wound. So it's important to have some type of occlusive dressing that can be placed over this, but again, allowing for ventilation in that wall. So you want to have this occlusive dressing that's covered perhaps on 3 sides with one area that's open, so that as a person takes a breath in, air does not draw into the chest wound, but rather as they compress and take a breath out, there's an open side of that occlusive dressing to allow air from the chest cavity to get out. So certainly this can be a very serious form of the disease, resulting in tension pneumothorax, which is this deviation where we see this unfortunate shift of the parietal tissue due to the significant development of pressure in the area. And of course, signs and symptoms, we're well aware of what this might look like. Of course, atelectasis, dyspnea, cough, chest pain, breath sounds are reduced, perhaps even absent, unequal chest expansion, hypoxia. Unequal chest expansion would be due to one of the sides of the lungs collapsed, and then interference with venous return could lead to hypotension. And so emergency treatment for pneumothorax, certainly transport to the hospital. For an open pneumothorax or a sucking chest wound, cover that with an occlusive dressing, as I mentioned, some of the details about that. Penetrating objects should not be removed from the chest until medical assistance is available. And if possible, tension pneumothorax should be converted to an open pneumothorax to alleviate some of the pressure that's developed. But again, that would require significant medical training to perform that technique. And finally, I'll conclude with this slide here, which addresses the management of respiratory problems in athletes. And so I'll have you pause the video to observe some of the different respiratory conditions, the evaluation, management, and important things to know. So with that, thank you so much for your attention. Hope you enjoyed our lecture on some of our respiratory pathologies.